dear scientists, dear friends, dear colleagues, good morning. Welcome to our third day of the Congress. I would like to introduce our moderator, Professor Dr. Mohammed Mahfoud Farhali. Professor, thank you for your agree to be with us today at our Congress and be as a moderator. And welcome Professor Ibrahim Abdelazim. Thank you for your agree give lecture today. Professor.
Welcome, Professor, welcome.
Please, you can start our section. Some participants will come, I think, and join to our section and lecture.
Good morning, everyone. Welcome to the International Symposium on Morphological Sciences, the session of Biology of Reproduction. Our first speaker will be Dr. Ibrahim Abdelazim. He is a professor of obstetric and gynecology and endoscopic surgery and reproductive medicine in Ancient University, Cairo, Egypt. He is also a consultant of obstetric and gynecology and endoscopic surgery in Al Ahmadi Kuwait Oil Company Hospital in Kuwait. Dr. Abdelazim is a certified Papillon Academy mentor and reviewer, and he is the editorial board member of the BMC series. Welcome, Dr. Ibrahim. Dr. Ibrahim. Did you hear me, Baljan?
Yes, I can hear you. Just
Dr. Ibrahim didn't hear me.
I am hearing you, Dr. Farhali, but can you hear me?
Yeah. Welcome, Dr. Ibrahim. You can start your session.
My voice is clear?
Yeah.
Thank you very much. Professor Farhali is one of best surgeon in obstetric and gynecology. I know him very well. Professor Farhali is a professor of obstetric and gynecology from my university in Egypt, and he is a consultant of obstetric and gynecology. He is also international researcher. Thank you, Professor Farhali, for the introduction.
Welcome. Thank you.
And thank you for the invitation from the International Symposium of the Morphological Science. Today, our session, I shared my slides. The slides are clear?
Not yet, Dr. Ibrahim. It showed the folder which we opened from it, but I think you must open the presentation first and then share the screen.
Okay, thank you. If the slide is clear, tell me.
No, open the presentation first and then share screen.
Okay, thank you.
Don't minimize it. Close share presentation. Or share screen. Close it. Don't share the screen. Open your presentation and then share screen.
I'm trying now.
Professor, should I help you? Should I
Yes, please.
Yes, of course. Okay.
If you have the presentation, it will be helpful if you have.
Yes, I have your presentation and I'm going to share it. Just
I'm trying also from my side.
Yeah, is
I
this the
stopped
right?
sharing from my side. I'm trying
Yes.
again.
Now it is clear.
No. I already demonstrated. Can you see it?
Okay. Yes. Thank you very much.
Okay.
I hope it's clear also for the attendee. So our presentation today will be about the development of the uterus and vagina from the Mullerian ducts, and this is surgical importance of this, the uterine cervix, and the importance of the surgical and the clinical importance of the uterine cervix, then the uterine supports and how this supports prevent the uterine prolapse. Then we will talk about the ovarian anatomy, blood supply, and the risk malignant index of ovarian tumors. This is the outlines of our presentation. Anatomy of the pelvic ureter and its surgical importance. Blood supply of the female genital tract, including the internal iliac artery, blood supply and lymphatic drainage of the vulva. The first, we'll talk about the development of the uterus from the Mullerian ducts. Hello? Hello?
We can hear
Yes,
you.
sir, we can hear
You
you.
can hear me. Okay.
Yeah,
And
we
the
can
slides
hear
clear.
you.
Okay,
Yeah.
thank you.
Is it correct slide now?
Yes, the correct slide is the
Okay.
development of the uterus from the uterus and the vagina from the Mullerian ducts. First, we have the ducts are developed from the coelomic epithelium lateral to the Wolffian system or mesonephric ducts, as clear in these slides from at 4 to 6 weeks of intrauterine life. So in this slide, we can see the para-mesonephric ducts, or what's called the Mullerian ducts, which is yellow in color, blue in color. It crosses the mesonephric ducts, which is red in color, and combine on each side of the midline. So the Mullerian ducts developed from the coelomic epithelium lateral to the mesonephric ducts at 4 to 6 weeks of intrauterine life. It lower end grow downwards and medially in front of the red color, which is the mesonephric ducts, and forming what's called the uterovaginal primordium. The uterovaginal primordium, which is the lower part, blue in color, joining which is the urogenital sinus at 9 to 10 weeks of intrauterine life. Then, after joining the urogenital sinus, this urogenital sinus gave what is called the sinovaginal bulbs. So then combination of fusion between the uterovaginal primordium and sinovaginal bulbs occur at 9 to 10 weeks of intrauterine life, and then complete fusion and canalization at 20 weeks. Finally, the upper part of the Mullerian ducts, which is funnel shaped, gave rise to the fallopian tube, which opened into the future peritoneal cavity. And this is slide. And then the middle part gave the fundus and the upper part of the body of the uterus. The lower part giving the cervix and lower third of the vagina. I hope also the figures are clear. Next. Then, so the urogenital sinus, which is this the lower part, gave most of the urinary bladder except the trigone, the urethra, and the sinovaginal bulb, which gave the lower third of the vagina. So failure of fusion between the uterovaginal primordium and the urogenital sinus, this lead to failure of fusion, which gave the transverse vaginal septum. While failure of canalization of the lower part of the uterovaginal sinus gave what's called imperforate hymen. I'm still hearing me? Hello?
Yes, Dr. Ibrahim, we are hearing you.
Okay.
Yes,
So
we
this
can
is a
hear
video.
you.
This is a video for how development of the Mullerian ducts on each side, which is the red color, both the red color, which is the Mullerian ducts from each side, join the other side and joining the urogenital sinus, which is the yellow color. The fusion of the Mullerians with the urogenital sinus gave the female genital tract. The upper part gave the fallopian tube. The middle part of the Mullerian duct gave the uterus. The lower part gave the cervix and the upper third of the vagina. Then the lower two-thirds of the vagina are developed from the urogenital sinus. So the transverse vaginal septum occurred due to failure of complete fusion. I'm now on slide 7, I think. The transverse vaginal septum occurred due to failure of complete fusion between the lower third of the vagina, developed from Ibrahim, and lower two-thirds of the vagina developed from the urogenital side. It's called, if this failure of fusion happen, it will lead to the what's called the transverse vaginal septum. The transverse vaginal septum can be diagnosed by ultrasound or by MRI, and this is the site of the transverse vaginal septum. It happened between the upper third and lower two-thirds, and this is the failure of fusion between the upper third and lower two-thirds of the vagina, which lead to the transverse vaginal septum. The transverse vaginal septum can be diagnosed by ultrasound or by the MRI, and can be identified by the MRI, the thickness and the location of the septum, and to exclude other anomalies. While the imperforate hymen, which is the red color, it occurred due to failure of canalization of the part of the urogenital sides. So clinically, both the condition transverse vaginal septum or imperforate hymen are presented usually in any girl or female at the time of puberty by primary amenorrhea, cyclic pain, then next slide, pain, the presentation. Next slide, please. So it can be presented by cyclic pain and amenorrhea, plus the presence of blood inside the vagina, and this blood inside the vagina, no, the previous one, previous slide. The presence of blood inside the vagina, which is called the hemocolpus, and the surgical treatment is the drainage. One slide before this slide, please. Another slide before this. So the surgical drainage or surgical removal of the septum is the treatment. This one, accumulation of the blood at the time of the menses, which is called the hematocolpus or hematometria. And the surgical treatment in this condition is removal of the septum or creation of the new opening in the hymen to drain this blood. Next slide, please. This is the surgical importance of the uterus and the uterine cervix. The cervix is split into two parts by the attachment of the vagina. The supravagina, after the attachment of the vagina to the cervix, there is a supravaginal portion of the cervix and there is vaginal portion of the cervix. Here there is difference between the epithelium lining of the supravaginal part of the cervix and cervical canal, which is covered by tall columnar purchase-ciliated epithelium, and the vaginal portion of the cervix is covered by stratified squamous epithelium. So the change of the epithelium from the vaginal part of the cervix from squamous to tall columnar inside the canal, it is called the transformation zone or the squamocolumnar junction. Most of the cancers of the cervix are originated from the epithelium, from the squamocolumnar junction after infection of the cells by the high-risk human papillomavirus. Next slide, please. So the human papilloma virus, it is one of the most powerful human carcinogen implicated in the cancer cervix, and it is the most sexually transmitted infection occur in lower and mid-income countries. Cancer cervix is, unlike other malignancy, is preventable disease after we will do an effective screening program to detect the early lesions of the cancer cervix. Therefore, the American Society for Clinical Pathology recommends screening of the cervical precancerous lesion using the pap smear for any woman sexually active between 25 to 64 years old. Next, please. The screening includes pap smear, which includes cervical cytology using the conventional pap smear or liquid-based cytology, co-testing for high-risk human papilloma virus with the cervical smear, then followed by what's called colposcopy for if we detect any lesion like high squamous intraepithelial lesion, low squamous intraepithelial lesion persistent, or atypical squamous cells or carcinoma inside. Can we go to the previous slide, please? So this is the way of screening for the cancer cervix. First, to do brushing or taking the cervical cytology. And if we detect in the examination of the cells, which is cytology of the cervix called the pap smear, next please, we will do colposcopy for any suspicious lesion. And this is staining of the epithelium of the cervix. And if we find any suspicious lesion using the colposcopy, we'll take a cervical smear for microscopic examination of the whole entire cell and the basement membrane to exclude invasive carcinoma. Next, please. Next slide, please. Then we will talk about the uterine support and prevention of the uterine prolapse. No, the previous one. The uterine support, which is mainly supports the uterus, preventing the uterus from falling down. Normally, the uterus is 80% in 80% of women is anteverted, anteflexed. Anteversion, this is the angle between the axis of the uterus and the vagina, which is 90 degrees. There is an axis between the uterine cervix and the vagina. This is called the angle of anteversion. Then there is an angle also of anteflexion between the axis of the cervix itself and the uterine body. So we have two angles between the uterus and vagina, or mainly the uterine cervix and the vagina. It is the angle of anteversion, which is 90 degrees. Then another angle between the body of the uterus and the uterine cervix, which is 170 degrees, and it's called the angle of anteflexion. This anteversion and anteflexion, it is one of the factors which prevent the uterine prolapse, and it's considered as one of the supports of the uterus from prolapse. So the factors which maintain the uterus in position and prevent the prolapse, first the anteversion and the anteflexion position, then the relation of the uterus to the surrounding structures, then the ligaments or the actual support of the uterus. Next slide, please.
Sir, may I ask you one question?
We can receive the questions now or at the end of the discussion up to the panel of the session.
They can text questions at the chat, and if they want the voice questions, then after. Please take note that.
So the supports of the uterus and the prevention of the prolapse is mainly the anteversion and the anteflexion position of the uterus. So with any increase of the intra-abdominal pressure, this will increase the angle of flexion and does not allow the uterus to be in a longitudinal axis with the vagina and prolapse. Then the normal relation of the uterus to the surrounding structure, for example, the anterior position of the bladder to the uterus, preventing the forward displacement of the uterus, and the rectum posteriorly, preventing the backward displacement of the uterus. Then the indirect support by the pelvic levator ani or pelvic floor muscles. Then there is a ligament of the uterus, the false ligament and the true ligament. The false ligament is the broad ligament, round, and ovarian ligament. So the
Dr. Ibrahim. Dr. Ibrahim.
It seems that he is suddenly out of our conference.
Yes. Let me to check.
Yeah, this is.
Okay, second, and Dr. Ibrahim will rejoin.
Okay, Professor Farhali, are you asking me to invite the next speaker?
No, second, and Dr. Ibrahim will rejoin.
Ah, okay.
I ask that if anyone had a question to put in the chat box. We already received only one question.
I have seen 2 questions there.
I saw only one from Wais Ali.
Yes, from what is Ali? Oh, okay. Another one just was the private message from Abhishek. He asked, what is the cause of the uterine prolapse? So I guess that this lecture is actually is the answer to this question.
Yes.
So Abhishek, please just listen.
Yes.
sorry for the interruption that happened. So we are coming back because there is some connection problem.
Welcome.
So now we are. I'm clear now, my voice?
Yeah.
Yes, we can hear you.
Can continue.
Okay. Thank you. No, now we are coming back to the broad ligament. The broad ligament is 2 ligaments attached on both sides of the uterus to the lateral pelvic wall. We have also the round and the ovarian ligament. The round ligament is fibromuscular band extending from the uterine cornea, passing through the inguinal canal to the labia majora. Another ligament which is called the ovarian ligament extending from the cornea of the uterus to the ovaries. So we have 3 ligaments as the false support of the uterus, false ligaments, which is the broad ligament, and this is the ovarian ligament and the round ligament and the ovarian ligament. So next slide, please. We are going now to the true ligament support of the uterus. The true ligament which is supporting the uterus are called the cervical ligaments, because these ligaments are attached to the sides of the cervix and the vagina to the lateral pelvic wall, and mainly the one of the yellow color, which is called the transverse cervical ligament or the Rhodes ligament. The green color, which is extending from the cervix, this central circle of the cervix, attached to the symphysis pubis, so it's called the pubocervical ligament or pubocervical fascia, and the one attached to the cervix to the sacrum is called the uterosacral ligament. So we have 3 ligaments, very strong ligaments, except one of the called the pubocervical called fascia, not ligament, supporting the cervix. This means support. The first one is the Rhodes ligament or transverse cervical, which is yellow color, strong one, fan shape extending from the cervix and the upper vagina to the lateral pelvic wall. It is surgical important. It contains what's called the ureteric canal, and this is the common site of the ureteric injury during hysterectomy, because the ureteric canal, the ureters pass through the Rhodes ligament or transverse cervical ligament through what's called the ureteric canal, and the uterine artery pass at the floor of the ureteric canal, which known by the surgeon is usually the water in the ureter under the breach caused by the roof of the canal by the uterine artery, and it is a common site of injury. The second surgical importance of the Rhodes or transverse cervical ligament is any spread from the genital tract, lateral pelvic wall is spread from the uterus and cervix to the lateral pelvic wall through the transverse cervical ligaments or cardinal ligaments or Rhodes ligament. Next slide, please. Then the green color is called the pubocervical fascia, not actual ligament, because this part is weak, extending from the cervix on each side of the bladder to the symphysis pubis, and this is why it is weak to allow distension of the urinary bladder, so it is called pubocervical fascia. The third one, which is strong, it's called the uterosacral ligament, extending from the back of the cervix and vagina on the sacrum pieces in the sacrum attached to the bone, the lower figure, which is the S2 and 3 and 4. So it's extending from the back of the uterus, mainly the cervix and the vagina, to S2 and 3 and 4. And this is the site of the sacrocolpopexy in cases of the uterine prolapse. And usually the tape for the sacrocolpopexy pass on each side of this is pelvic wall. Next slide, please. So we did modification for this attachment of this artificial ligament, which is in the lower image, and this published on one of the PubMed journals through we did it in the West Kazakhstan Medical University. So instead of putting the sutures on both sides of the colon, we take an artificial tape and make it at a Y-shaped ligamentous support for the uterine prolapse, and it will be attached directly not to the S2 and 3 and 4, it will be attached to the promontory of the sacrum. And this is one of the surgical importance for the ligaments and support of the uterus using the artificial ligament and what's called the Merceline tape. Next, please. Then we will come to the surgical importance of the ovaries. The ovaries are called the female gonads, and the ovaries is two parts mainly of the ovary. The outer part, which is the ovarian cortex, which is yellow in color, containing the ovarian follicle in different stages of development, and then the inner part, which is called the medulla, containing the blood vessels and stroma of the ovary. So the outer cortex in the lower image, we can see the ovarian follicles in different stages of development, from primary oocyte to secondary oocyte, then mature oocyte, which ovulate. Next, please. And we'll come to the surgical importance of this cortex. Next slide, please. Next, please. So what is the surgical importance of this anatomy of the ovary? And usually during the surgery, we are doing electrocoagulation or diathermy for the ovarian cortex, and this will negatively affect the ovarian reserve or the number of the follicles inside the cortex. So it will affect the future ability of any woman to get pregnant and the reproductive goals. Another, respective to electrocoagulation or polypolar coagulation, another study concluded that any surgical techniques in the ovary, irrespective to the hemostatic methods using electrocautery or diathermy, will affect the ovarian reserve. And this is one of the nice laparoscopic view for the normal ovulation. You see the yellow color oocyte, mature oocyte is coming out of the ovary. Next, please. Moreover, we reported a case that without even using diathermy or using cautery or what's called bipolar or unipolar polar coagulation, we found that women 36 years came by the ovarian fibroma, and then after surgery and removing of the fibroma using only stitches. So we found the LH and the FSH elevated for 1 year after surgery. So in the lower image, you can see the fibroma, and you can see the yellow in the table, which is the FSH elevated from the December 2018 till December 19 till it become normal 3.3. So it was 24 milli international unit after surgery, and it is elevated yellow color till it come 3 after 1 year, December 2019. So after 1 year, without using any diathermy or coagulation, using only stitches, we found an elevated FSH and LH for 1 year after surgery. So we published this as what's called decreased ovarian reserve after conservative ovarian surgery for benign lesion other than endometriosis. So as a conclusion, we would like to ask the surgeon to should avoid or minimize the normal tissue, ovarian tissue damage during surgery, and they should counsel the patient. No, we're still in the previous slide. We should counsel the patient that any surgery will affect the ovarian reserve, and any ovarian reserve should be followed after surgery, which may affect the future fertility and reproductive ability of any women. Next, please. This is regarding the ovarian cortex and the mature follicle. We have also anatomy of the ovary, and this figure is actually very important because it explains to us the anatomy of the ovary, relation of the ureter to the ovary. So the ovary occupies what's called the ovarian fossa in the figure, and this ovarian fossa is directly related posterior to it, the ureter and the internal iliac vessels. If we can see also the drainage of the ovarian vein, it is on the left side draining to the left renal vein up. And then the ovarian artery is directly branched from the abdominal aorta at the renal vessel. So this figure is very important regarding its anatomy and the relation of the posterior relation of the ovary. And the drainage of the ovarian vein on the right side, it is directly to the inferior vena cava. So this is the blue color in the figures, is the venous drainage. On the right side, it drains to the inferior vena cava, and on the left side, it drains to the what is called the left renal. And the origin of the ovarian artery, it is from the abdominal aorta at the level of the renal vessels. Posterior relation of the ovary, which is the yellow color, is the ureter and the internal iliac vessels. So also the lymphatic drainage of the ovary is coming directly to the lateral para-aortic lymph nodes and to the internal iliac lymph nodes. So this is why, next slide please. In any ovarian malignancy, so the ovarian malignancy is drained immediately to the lateral pelvic, lateral para-aortic lymph nodes. So the ovarian cancer has vague symptoms usually, and it's called the silent killer. In addition to the silent occurrence of the ovarian cancer, it's spread directly to the para-aortic lymph nodes. There is no universal screening method for the diagnosis of cancer ovary. So the United Kingdom collaborative trial for cancer ovary screening recommended screening of the ovarian malignancy using the multinodal screening technique. This multinodal screening technique using the CA125 plus the transvaginal ultrasound to calculate what is known as the risk malignancy index. So the risk malignancy index is calculated from the level of the CA125, which is a tumor marker, multiplied by the menopausal status, multiplied by the ultrasound finding of the ovary. So for example, the menopausal status, it is given 1 for the perimenopausal women and given 3 for the postmenopausal women, multiplied by the absolute value of the CA125 multiplied by the ultrasound features. Next, please. So then how we calculate the ultrasound features? According to this is diagram showing how it looks in the ultrasound. This is the cyst inside the ovary, which is the black color. This is cyst black color with solid component. Solid component appears as gray color. Then single cyst or multilocular cyst. So this one is the cystic with the solid component, yes, in P. In number C, it is called the multilocular cyst, yani cyst with more than one locule inside. In D, figure D, there is multilocular and also there is a solid component. In E, it is totally solid component in the ovary. So depending on the ultrasound feature, it is bilateral lesion, multilocular, there is a solid component, there is abdominal metastasis or nodules. The ultrasound score is 0 if we cannot find any of these ultrasound features. And the ultrasound score is 1 if we found one of the features. If we find 2 features or more than 2, it's giving ultrasound score of 3. So at the end, we calculate the risk malignancy index. If the risk malignancy index at a cutoff value of 200, it had 85% sensitivity and 97% specificity in diagnosing ovarian cancers. Next, please. Then we'll go to the anatomy of the pelvic ureter. The similar figure, the ureter, which is behind the ovary, and it is yellow in color. It is pelvic part of the ureter is about 10 centimeters. It enters the female pelvis by crossing in the figure, upper figure, by the bifurcation of the common iliac vessels. Then it goes downward in front of the internal iliac vessels behind the ovaries. At the level of the ischial spine, the lower image, the ureter goes medially and forward, entering the ureteric canal, as we said before, in the transverse cervical ligament or Rhodes ligament to go to the trigone of the blood. So the ureteric canal here is 1.5 centimeter lateral to the cervix and vagina, and this is a common site of injury during hysterectomy. So in the figure, upper figure, you can see the ureter going down, crossing the bifurcation here of the common iliac, posterior to the ovary. And then in the lower image, it goes downward and forward through the Rhodes ligament to enter the trigone of the blood. Next, please. So what is usually the ureter can be injured in some gynecological surgery, and one study found that 82% of the ureteric injury occurs during pelvic and gynecological surgery, especially the ureteric canal in the Rhodes ligament. And so we would like to identify the ureter before these steps. And what is the procedure or the surgery for the ureteric injury? Usually the ureteric injury occurs during hysterectomy, what is abdominal or vaginal or laparoscopic, during internal iliac lymphadenectomy for surgical staging of malignancy, sometimes bilateral internal iliac ligation as a life-saving procedure in postpartum hemorrhage, sometimes during adenexectomy or removal of the ovarian swelling, especially in malignancy or endometriosis. Next, please. Also, the risk of injury is increased in presence of congenital malformation of the genital or urinary tracts, if the anatomy is distorted in cases of ligamentary or cervical fibroids, if there is any adhesion or pelvic malignancy or endometriosis or pelvic infection. Sometimes there is blind clamping of the bleeding vessels to stop massive bleeding or life-threatening hemorrhage. To avoid this injury of the ureter, would like to recommend preoperative identification or intraoperative identification. Either preoperative using intravenous pyrography, IVP, preoperative ureteric stenting, and intraoperative identification, or clamping under vision, and to avoid blind clamp. And this video, we can see it is a method of identification of the ureters intraoperative by insertion preoperative ureteric casters. So this one of the Indian surgeon, he is my colleague in India, and he is using the ureteric casters illuminating during hysterectomy. So you can see the ureters identified and illuminated during laparoscopic hysterectomy. So we can go away from the ureters and avoid this injury. And you will see during the video also how we are near during our surgery to the ureter. Here is the ureter illuminating posterior to the ovaries, the right and left side. And during clamping or diathermy and coagulation of the feeding vessels for the uterus, you will find very near to the ureter, and this is the importance of identification. This one was still clamping, ligation, and diathermy of the to conserve the ovaries. Then we are going deep to diathermy, diuterines. You will see how we are near to the ureters and the importance of the identification. See, we are going down here in the pelvis, the section to go to the uterines. We are very near to the ureters, which is illuminating, and this is the importance of the identification to avoid this injury. See this, how near we are to the illuminating ureters. Also near, very near. So once we are identified the ureters, we avoid the injury during surgery. Next slide, please. Here by the anatomy of the internal iliac, because the internal iliac is the main blood supply of the pelvis. The internal iliac is one of the two terminal branches of the common iliac. In the upper figure, you will see the aorta dividing into two common iliacs. The common iliac is divided into internal iliac and external iliac. So the internal iliac, which is the main blood supply, it is one of the two common branches of the common iliac divided into internal and external iliac. Yes?
Only 5 minutes is remaining.
Okay, I'm finishing, inshallah. So what is the relation between the internal iliac is anteriorly to the internal iliac, there is the ureter and ovary, and posterior relation is the internal iliac vein. The end of the internal iliac is divided into the greater upper border of the greater sciatic foramen, into dividing into anterior and posterior division. Next, please. So what is the branches from the internal iliac? So the internal iliac giving anterior division and posterior division. And this figure, our image is very important, giving the internal iliac dividing into anterior division and posterior division. This is the posterior division dividing into iliolumbar, lateral sacral, and superior gluteal. This is the anterior division of the internal iliac, which is under the artery or the clamp. It is one of the main blood supply of the pelvis, and it is gave the uterine, superior vesical artery, inferior vesical artery, middle rectal, obturator branch, inferior gluteal, and internal iliac. So what is the surgical importance? The ligation of the internal iliac can be life-saving procedure before hysterectomy for massive bleeding and what's called during after delivery postpartum hemorrhage. So this is the surgical importance, internal iliac ligation, to save the mother's life in cases of postpartum. Next, please. The last one is the lymphatic drainage of the vulva and its clinical importance. So the blood supply of the vulva is the internal duodenal artery. What is the one of the two terminal branches of the internal division of the internal iliac? This is the main blood supply. The second blood supply is the superficial and the deep external duodenal arteries from the femur. And here, this figures explaining the lymphatic drainage of the vulva. Usually the vulva on left or right side draining to the inguinofemoral lymph nodes on the same side, what's called the ipsilateral inguinofemoral lymph nodes. And when the inguinofemoral lymph nodes, the upper part, which is called lymph node of Croquet, enlarged, means this malignancy of the vulva is already spread to the obturator, internal iliac, and then external and common iliac. So this lymph node of Croquet is important in the spread of the malignancy of the vulva, which is the uppermost lymph node in the femoral canal. Only the exception from this, the midline structure of the vulva, which is the clitoris and the posterior fourchette, it can be spread to both sides of the inguinofemoral lymph nodes. Thank you very much, and thank you for the technical support. I finished the presentation. And thank you for the invitation from the committee.
Thank you, Dr. Ibrahim.
Thank you, Professor Farghali.
Which is very clear and showing all the anatomy of the pelvis.
Because usually we're facing the anatomy every day in our surgery.
Yes. It is very important to know the anatomy of the pelvis.
Thank you, Professor Farghali. Thank you for the organization committee. And sorry for the short of the time, because the presentation is actually long to summarize everything.
You are welcome, Dr. Ibrahim. Concerning the question, first question from Wa Sali is asking you, why there is a changing of the epithelium lining of the cervix from tall columnar to stratified squamous epithelium? What is its purpose?
Now, this change from the epithelium is related to the development of the Mullerian ducts, as we said in the first development from the Mullerian system. Two canals fuse in the midline. So the fusion of the Mullerian canal, the upper part gave the fallopian tube, the middle part giving the uterus, the lower part giving the cervix. So the cervix, development of the Mullerian duct, and give upper third also of the vagina. The external cervix is covered by stratified squamous epithelium like the vaginal epithelium, which is normal. The inner cervix or the upper part divided by tall columnar, partially ciliated. It is similar to the endometrium epithelium because it's part from the uterus. And the lower part is considered part of the vagina. This is a change of the epithelium. It is normally related to the embryological development. And this is called the squamocolumnar junction, the site of most of the malignancy of the cancer of the cervix.
Yes. No other questions?
I hope the answer also is clear.
Yes, very clear. I want to ask you, why you think that incidence of ureteric injury is higher in laparoscopic surgery than open surgery?
Maybe due to it is not a direct injury. Maybe it is disseminating of the thermal injuries through the diathermal technique. But most of the laparoscopic surgery is not taking the suture ligation or can identify and dissect. They are using diathermy, using the monopolar or bipolar technique. So most of the injury in laparoscopic, it is not direct injury for the uterus like clamping or taking stitches. Yes. And most of this due to thermal dissemination to the lateral pelvic wall. As we saw in the video, they are using diathermy.
Yes.
And this diathermy, it is not causing injury, even identify the ureter and then the sect and the diathermy and the cutting. It is thermal dissemination of the power of the diathermy to the lateral pelvic wall. It's called the indirect injury, as I think.
Yes, yes. And this is the difference between different estimates in laparoscope, each one causing coagulation or diathermy to which extent and outside our goal.
Yes, sure.
Okay, we want to thank Dr. Ibrahim. Thank you, Dr. Ibrahim, for your this valuable presentation. And we'll
Thank
go
you,
to
Professor Falghari. Thank you for the moderator of the session. We helped me through the technical problems. Thank you very much.
Thank you, Professor. Could I put just one short question, please?
Yes, welcome.
About that video that you demonstrated of the Indian doctor when he made this ureters visible. Is this something
Yes.
that is manufactured or something that is handmade device?
No. It is ureteric catheterization. Yeah, I mean, before, as we said, the methods of the identification of the ureters, and it is to be safe surgeon, you have to identify your ureters before. As we said, there is 82% of the ureteric injury are happened during gynecological surgery. So the pelvic surgery itself, it is a risk of the ureteric injury. So we have before our surgery to identify the ureters. How to identify the ureters? Either to do what is called preoperative intravenous pyelography, IVP. Some of the surgeons are inserting normal ureteric casters. They can feel these casters inside, which is rigid, and to be away from the casters. Myself, I am identifying the ureters intraoperative, dissecting the lateral pelvic wall and identify the ureter by myself. I don't need insertion of the ureteric casters. Some of the other doctors are avoiding dissection on the lateral pelvic walls and inserting the ureteric casters. There is two types of ureteric casters, either to feel it during the open surgery, inserted preoperatively, and you feel the ureteric casters inside the surgery, is the rigid casters, to be far away from the casters. In laparoscopic surgery, we are not feeling the ureters. We are doing under vision. So these casters are already in the market, and there it is not handmade, and they are inserting the casters pre-operative before going for the laparoscopic extraction. And it is manufactured and it is in the market. The advantage of this caster, it is illuminated. So you can see the ureters and to be away from the ureters as much as possible.
Thank you. Thank you very much.
Welcome.
Next talk will be Professor Solia Palmegamatova. Unfortunately, she is not with us due to family issues, but she left her video where her talk will be on human papilloma virus presence in low risk and low grade cytology smears of women aged 30 plus in West Kazakhstan. Baljan, if you can please.
Yes, I'm going to demonstrate it. Да, можете начинать.
Dear colleagues, good afternoon, dear colleagues. My name is Saulia Balmagambetov.
Could you hear her voice? Could you please?
Yes, we can hear.
Yeah. Okay.
I am gynecologist oncologist from Aktuber, West Kazakhstan University. The issue I'm going to present today is referred to as burning topics of current oncology in terms of cervical cancer prevention, HPV presence in low risk, low grade cytology findings in women 30 and over years old in Western Kazakhstan. could you, the next slide. According to the Lancet Research Group prognosis, we should expect rising the number of cervical cancer diagnoses by at least 25% by 2030, mainly in low and middle income countries. There is a lot of predisposing causes for that. Among them, unavailability of the regular screening in some countries, insufficiency of current screening modalities, such as a limitation by age or imperfect screening tools, occurring the invasive cancer caused by HPV types of low risk in aged women, low awareness and consequent low attendance, the screening procedures, and other reasons. As to our country, Kazakhstan, cervical cancer consistently ranks second within the most frequent cancers of women's reproductive system, while breast cancer, of course, is leading in this rating. Experts from the Barcelona's group, who constantly monitor the cervical cancer situation worldwide, estimated annual crude incidence as 18.2 per every 100,000 women as of 2019, and this index undoubtedly high. Следующий слайд можно? In this slide, the screening modality in Kazakhstan is shown amongst the borderline and neighboring countries. As you can see, main and the only tool in our country is cytology performed by two means. The liquid-based cytology with the preservation media cell scan manufactured in South Korea, and simple azure eosin staining used as opportunistic method. In Turkey, for example, the screening strategy was revised in 2014, and HPV DNA testing became the primary tool, while cytology used for triage, according to current commonly accepted conception. The next slide, please. There are some reasons why HPV monitoring is very important even in women of low risk and having low-grade cytology findings. First, although more than a half of women with low-grade cytology will have a negative co-test, it means HPV negative and neum in cytology. At their rescreening, every fifth of them will be diagnosed with CIN2 and over in the subsequent 3 years. Women referred to colposcopy based on initially HPV positive neum co-testing constitute a sizable population, about 20% of all colposcopy referrals. The 3-year risk of CIN3 and over is similar to the risk for HPV positive ASCOS and HPV positive LCL referrals. It means colposcopy results predict very similar risk of CIN3 and over, and therefore they should be clinically managed as a single group. The next slide. The particular study presented today is a part of a large comprehensive research on HPV infection and attributable diseases in women of Western region, having published protocol and being registered in database for observational studies. Study setting: RT PCR HPV made by Russian technology, and cytology smears, LBC cell scan, South Korea, and Azure Elzin staining were collected in general female population aged 18 to 60 years throughout the 4 western provinces of Kazakhstan: Aktobe, Ural, Aktau, and Atral. History of HPV vaccination was the exclusion criterion. We defined low-risk patients as women aged 30 to 65 years with no prior and present abnormal pap smears, no gynecology-oncology history, no prior hysterectomy, and non-pregnant. The next slide, please. Speaking of the HPV presence in low-grade smears is impossible without some important information from the mentioned comprehensive study. We found HPV prevalence in the region as almost 25% of all women examined. It means 291 out of 1,166 women. Besides, every 5th woman was infected with the HPV of high carcinogenic risk, so-called HR-HPV. Some women were carriers of multiple HPV infection, up to 6, more than a quarter of women. We used reagent kits of Russian manufacturer, ranged for 21 strains, which are presented in the slide. The next slide. We determined HPV and cytology state in every woman separately due to absence of appropriate equipment to get HPV directly from the preservation media. Besides, due to funding limitation, we failed to provide each of these more than 100 of women with liquid-based cytology, but the Azure Elzin staining was provided for all samples. Thus, we determined HPV presence or absence for all cytology assays and revealed 36.5% of all Vaginal findings infected with HPV. As the ASCUS and SIN1 findings are also referred to as low-risk cytology, the proportion of HPV presence in low-grade, low-risk findings is very significant, more than half. In frames of the comprehensive study, we also revealed sensitivity and specificity of cytology tools we use every day in our practice throughout the country, and found discordances, which you can see at this slide. Data on HPV presence and type distribution in smears with invasive cancer were obtained separately in frames of the case control study. Here are HPV type distribution in sample of women newly diagnosed with invasive cervical cancer of different stages. Please pay attention on the 2 moments. Top 5 HPVs in this sample are HPV 16, 31, 18, 33, and 45. It means almost identical to those in the smears of low risk, low grade, which will be presented below. These are types 16, 52, 31, 18, and 45, respectively. The second moment, we found 3 cases of invasive cancer in women older than 60 years caused by HPV types 53, 2 cases, the age of women 60 and 72 years old, respectively, and 1 case caused by type 73, woman's age 75 years. All these cases were mono-infections. It means we found 3 cases out of 73 where cervical cancer was caused by types of low probable possible risk, not of highly carcinogenic group. This phenomenon is referred to present peculiarities of the cervical cancer biology and clinics and may have a significant impact on the current prevention strategy. Here we found necessary to present cervical cancer incidence trends by age groups within 5 years, 2014-2018 in Western region. Please pay attention to the annual percent change in the group of 70 and over years, the highest among others, 13.6%. This is also a present particularity of cervical cancer epidemiology throughout the world. Thus, our data are in line with the findings of researchers from other countries. Results of a study on HPV presence in low-risk, low-grade cytology smears. All HPV positive findings in women 30 and over years old were stratified by grouped cytology status. As such, eventually we operated with 166 HPV positive assays of a total 291, which is equal to 57%. We selected women who meet the definition of low-risk patients presented previously. It means women aged 30 to 65 years with no prior and present abnormal pap smears, no gynecology oncology history, no prior hysterectomy, and non-pregnant. Among the HPV positive women aged 30 and over years, the majority, 40.4%, were in the high categories of viral load. Baseline data are provided in table below. Could you? This is a table where almost all our findings are presented. The next slide, please. Across the 3 groups of cytology findings, we found no statistically significant difference in age of women by the Krasker-Wallis rank sum test. Besides, the age of women's sexual debut appeared to be relatively homogeneous throughout the sample. Consecutive increasing a share of the most carcinogenic HPV-16 by groups 1 to 3 is observed from 21.7% up to 37.2%. The severity of cytology change grows as the proportion of type 16 rises. Kendall's tau is 0.26, moderate at significant p-value. Average viral load rises consecutively from the nil toward SIN1. The next slide, please. Here is the HPV types distribution in the low-risk, low-grade smears. Please pay attention to the top 5, which is almost identical to those found in the verified cancer samples. HPV 16, 52, 31, 18, and 45. Allow me to remind data from the Kaiser Permanente Hospital, where more than hundreds of thousands cases of low-risk smears were analyzed. Although more than a half of women with low-grade cytology will have a negative co-test at their rescreening, every sixth of them will be diagnosed with SIN2 and over in the subsequent 3 years. Accordingly, how many of them will be diagnosed with invasive cancer after the decade of insufficient screening without HPV monitoring or its absence at all? The next. Thus, in frames of the study on HPV presence in low-risk smears, we revealed high HPV prevalence in the neum smears. Neum means negative intraepithelial lesions or malignancy. It means benign smears. So HPV prevalence in the neum smears was 36.5%, and in overall the low-risk, low-grade cytology findings was 57%, along with the most carcinogenic type 16 predominance at 28.8%. In the low-risk, low-grade cytology smears of women of 30 and over years across Western Kazakhstan, leading top 5 HPV types are almost identical to those from the smears obtained in women affected with cervical cancer of different stages, from TIS to stage 3B. The next slide. According to Schiffman with co-authors, viruses from the Papaviridae family are known to be able to constant evolution, and HPV is currently defined as types of possible probable risk. There is a range of such types are also undoubtedly proven to be causative agents of cervical cancer. Known expert in this field, Mark Arben, suggests to increase the number of highly carcinogenic HPVs from 13-14 currently in use up to 20. Currently observed throughout the world growth of cervical cancer incidence in the age category 70 and over years, it means beyond the age of the screening examination, calls for making the HPV status in population available for monitoring during all their life. Overall, studies on HPV and cervical cancer in low and middle income countries should be enhanced. HPV prevalence in western provinces of Kazakhstan is high enough and equal to 25% to explain relatively high corresponding incidence of cervical cancer. Screening tools applied in the country, cytology means only, are not sufficient for timely diagnosing precancerous lesions to prevent cervical cancer onset. Overall, the screening modality in the country should be revised according to current global conception. Molecular HPV testing for primary screening and cytology for triage. So, thank you for your attention, dear colleagues.
Thank you, Professor Solia. Our next presentation will be with Professor Sulaimonova Mata Jona.
May I ask a question, Dr. Farghali?
Unfortunately, Dr. Ibrahim, Professor Solia is not with us. This is a video, so she cannot.
In general, for the discussion, I'd like to clarify something about the HBV vaccination.
Yes.
Yeah, and also I can, I can transfer the question, and also I will send her email. So any questions further, you can also email her. The discussion is also very
already,
good. Yeah.
You answered already my question about the HBV vaccination.
Yeah.
Which is very relevant to our branch. About the HBV vaccination, which is approved in some countries and not approved in some countries. HBV vaccination is, for example, in Kuwait, we try to apply the HBV vaccination for prevention of cancer cervix. But some of the Ministry of Health up till now, I don't know, Dr. Farghali is working in the Ministry of Health, which is approved or under processing or not.
No, until now, not approved, Dr. Ibrahim.
It is not approved in the, so we are not approved in Kuwait because, as you said, maybe the parents are afraid of the vaccination. The second question, it is what type of the vaccination? It is approved, as you answered me, in the Kazakhstan, but what type of the vaccination? There is Gardasil available against 4 types of HBV, and maybe another one recently against 9 types of HBV. Which type of vaccination is available in Kazakhstan? What is the criteria of this vaccination for the girls? And if one woman infected by one of the HBV virus, maybe Dr. Farghali will be able to answer me, it can be vaccinated against the other types of HBV or not?
Yes.
If it is infected by HBV, example 9, number 16 and 18, I can give her the vaccination to be protected against the other types of HBV virus. Thank you, Dr. Farghali, for that.
Welcome, Dr. Ibrahim. Our next talk will be by Professor Sulaimanova Imata Geona. She's an associate professor of the Department of Histology at Tashkent State Medical University and associate professor of in Department of Morphology and Pathology in St. Petersburg University, Hbv. She will talk about the pro-carcinogenic effect of the anti-estrogen fulvestrant on the ovary of offspring of laboratory mice. Welcome, Professor Sulaimanova.
Thank you very much, Professor Muhammad Farghali. Dear colleagues, today I will present my speech on the topic. Thank you. This is my slide. Where is my presentation?
Хотите, чтобы я презентовала? Хорошо.
Да.
Хорошо, хорошо.
Спасибо. Балдян, спасибо. Pro-carcinogenic effects of the anti-estrogen fulvestrant on the ovaries of offspring of laboratory mice. The aim, the next slide, please, Baljan. Thank you. The aim of the study is to determine the limiting subtoxic doses of anti-estrogens that provoke obvious structural disorders of the reproductive organs of offspring at critical periods of their development when they are introduced during pregnancy into the mother organism. The next slide. Methods. The studies were performed of the offspring of white laboratory mature female mice, weighing 19 to 21 grams, which were divided into 2 groups. The next, please. Thank you. The control group of pregnant mice was injected with castor oil at a dose of 0.8 milli intramuscularly. The experimental group of pregnant mice was injected with a fulvestrant preparation, 0.4 milli of a 0.005% castor oil solution at a total dosage of 100 microgram per kilogram of the weight on the pregnant mouse intramuscularly. Thank you. Treatment to both groups of the pregnant mice was performed at the developmental stage E11.5. And the female offspring obtained from these groups of pregnant mice on the 90th day. The ovaries were examined. The organs were fixed in 10% neutral buffered formalin for 24 hours, subject to standard histological processing. Standard histological section of the ovaries were stained with hematoxyliniazine and immunohistochemical method for expression of P15-3 receptor. Sections stained with hematoxyliniazine were subject to morphometrical analysis. Thank you. The next slide, in this slide, you can see histological preparation of our studies. Intramuscular injection of fulvestrant to mothers has given the possibility the observation of the follicles of different stages of their development in female offspring and puberty. This is an increase in the number of primary follicles, and this displacement deep into the organs to the medulla. The pronounced predominance of secondary follicles with signs of CT examination is also determined. The follicular epithelium is thickened in them, and single yellow bodies have signs of severe dystrophy with atrophy of the follicular epithelium. The thecal layer of the corpus luteum and flagenet in the stroma of the ovary focal luteinization is not the follicular epithelium without and thecal layer with signs of secretory activity. In the cortical layer, depletion of blood flow in the vessels is not. In follicles, the expression of the P15-3 tumor suppressor protein is 0%. The level of nuclear expression of P15-3 in the ovarian stroma is up to 1% in the corpus luteum, and strong expression of P53 is 3 and 4%. Conclusion. Thank you. The intramuscular injection of the anti-estrogen fulvestrant drug to pregnant mothers of mice during prenatal line, the development of reproductive organs leads to clear but moderate signs of atrophy and the same time of disorder of the overall structure of the ovaries of female offspring in the late postnatal ontogenesis. These changes can be qualified as pro-carcinogenic in general. Thank you for your attention. Thank you very much to the organizers of the symposium, and I wish all the members good health and good luck. Thank you. Good luck.
Thank you. Any question to Professor Sulaimanova? Okay, we can go to the next presentation. Next presentation will be by Professor Maria Garcia Palmaini. She is an Associate Professor of Human Anatomy, Department of Life, Health and Environmental Science in University of L'Aquila, Italy. Welcome.
Thank you very much, Professor Farghali, for the kind introduction. And before starting, let me thank Professor Zurabekova for the kind invitation. I'm very glad to be here today with you. Sorry, just one moment. Oh, sorry. The polycystic ovarian syndrome is a metabolic and endocrine condition that was firstly reported by Stein and Leventhal in the far 1935. Syndromes include hyperandrogenism, oligo-ovulation, and polycystic ovaries. And it is normally associated to insulin resistance, metabolic disorders, and infertility. There are three criteria that allow us to define the diagnostic criteria. In 1990, the National Institute of Health defined this symptom with oligoanovulation, androgen excess, exclusion of other disorders characterized by menstrual irregularity and hyperandrogenemia. More recently, the Rotterdam Consensus included also the presence of polycystic ovaries by ultrasound. And on 2006, the Androgen Excess PCOS Society added also the exclusion of other disorders characterized by menstrual irregularities and hyperandrogenemia. As you can see here, symptoms are very different, ranging from excessive body hair growth, weight changes, and difficulties in losing weight, ovarian cyst, low sex drive, irregular or missed period. Normally, levels of testosterone are very high, and there is, as we already said, insulin resistance, fatigue, acne, mood changes, but most importantly, there is a connection with infertility. The pathogenesis of PCOS include genetic factors, hyperandrogenemia, hyperinsulinemia, and this condition foreseen the presence of reproductive aberrations, hyperandrogenism, oligoamenorrhea or amenorrhea, obesity, insulin resistance, acanthosis nigricans. The problem is that the molecular mechanisms leading to PCOS establishment are yet unclear. So this is a problem because it limits the therapeutic strategies. Many studies have suggested a central role for oxidative and glycative stresses in the pathogenesis of this syndrome. And it's very important the role of a decreased antioxidant capacity in the patient with PCOS. Last year, we published a paper in which we described this syndrome in a model of PCOS, in which we added the DHEA, the hydroepiandrosterone, in mouse for 20 days. We induced this syndrome, and we found the connection with the methylglyoxal-dependent glycative stress together with the deregulation of the sirtuin-1 functional network. In that study, we could observe by morphological study the presence of an altered collagen deposition, as we can see with the trichrome staining, in which here you can see the control, and here the PCOS model. There is an increased presence of collagen, so showing a fibrotic aspect of the cortex and the medulla in the PCOS model, associated with an increased vascularization, as we can see in green with the von Willebrand factor and in pink with the alpha smooth muscle actin. Similar results were obtained with about another steroidogenesis that was relieved in PCOS with the 17-beta hydroxysteroid dehydrogenase type 4, and the presence of lipid droplets were significantly increased in PCOS model respect to control, as evidenced here with the body pie staining. Moreover, we found also increased level of MGH, indicator of glycative stress, in a DHEA-induced PCOS model. Here we can see a strong immunostaining for MGH that are methylglyoxal advanced glycation end product in a PCOS model. And finally, we found also a decreased level of translocates of the outer mitochondrial membrane 20, the so-called TOM20 that is indicated in red, who actually decreased its expression, as also we can see here for the quantitation, in which we found a significant decrease of this marker TOM20. That is very important because it's an indicator of the functional machinery of the antioxidant capacity. So this means that there is a reduction of the antioxidant capacity in PCOS animals. And in fact, actually, there is an important recommendation for patients with PCOS in using antioxidant. That's why PCOS patients consuming antioxidants present an amelioration of ovarian function and morphology with a reduction of oxidative stress. In this image, it is very easy to understand how the PCOS pathogenesis is connected with nutrient deficiencies. That's why it's very important to have a diet with include vitamin supplements, vitamin-like nutrient supplements, mineral, and other supplements. For example, it's very important the role of vitamin, inositol, bioflavonoids, but we focus our attention on the study I'm going to present with the role of carnitine. The antioxidant L-carnitine can be synthesized endogenously or obtained for dietary sources. It is essentially in fatty acid metabolism by facilitating the transport of long-chain free fatty acid into the mitochondrial matrix. It is involved in alpha ketoacids intramitochondrial shuttling or oxidation, and carnitine shuttles acetyl groups from inside to outside the mitochondrial membrane. So it's very important in regulating glucose metabolisms and sensing cellular energy level. That's why we can note that L-carnitine has a direct antioxidant properties, protect mitochondrial metabolisms, and modulate the activities of ROS-producing enzymes. So due to these numerous regulatory functions of carnitines and their esters in the energy metabolisms and mitochondrial function, we decided to investigate the effects of carnitine and its endogenous ester. There are short-chain carnitine ester, in particular acetyl carnitine and propionyl carnitine, on this syndrome. To this aim, we employed the same model previously showed, so developed in CD1 mice strain, treated with dehydroepiandrosterone for 20 days, and we focused the possible modulation of oxidative and glycative stress previously characterized. To this aim, we used a CD1 mice adult with a body weight of about 20 grams, and we injected these animals with DHEA for 20 days alone, control, or together with with the two different formulation of carnitine, the formulation 1 together that include acetyl carnitine, and the formulation 2 that we will call C2, in which we found the concomitant presence of acetyl and propionyl carnitine. So experimental groups are 4, control, the DHEA plus C1 and plus C2. After treatments, animals were euthanized and ovaries were collected and subjected to normal preparative for hematoxylin, eosin staining, ASAM trichrome staining. Lipid droplets were revealed by immunofluorescence for the thanks to the body pie staining. And MGH and 4-hydroxy-nonemal staining were made by immunohistochemistry. Analysis of by light microscopy after hematoxylin and eosin staining evidenced that carnitine formulation decreased follicular atresia that were found in DHEA phenotype, characterized by a very a low presence, a reduced presence of growing follicle and abundant presence of corpora lutea and collagen infiltration, a fibrotic aspect. Both formulations, so both C1 and C2, decreased follicular atresia. And also, the number of atretic follicles were counted, and we can see the protective effect against atresia. Connected to the presence of collagen that were abundantly available in the DHEA phenotype, the administration of carnitine 1, but especially carnitine 2, ameliorated the collagen deposition, because in the C1 group we still found an abundant presence of collagen both in the growing follicles and in the stroma, that decreased significantly in presence of the carnitine 2. The administration of both carnitine formulation had a positive effect on the concentration of lipid droplets that significantly decreased respect to DHEA in both C1 and C2. Lipid droplets were present mainly in the corpora lutea of growing of the ovaries. Carnitine formulation also decreased lipid peroxidation that were evidenced by 4-HNA, special marker of this phenomena. Peroxidation that was evident in the DHEA group and decreased in presence of both C1 and C2 ovaries. Connected the presence of advanced methylglyoxal glycation end products, we could see that carnitine 2 only had a protective effect, because we found a similar situation to control. Differently, in DHEA, the staining was very strong and quite similar, even if not at the same level. It was evidence in the presence of the carnitine formulation 1. So both carnitine formulation tested in this work showed some beneficial effects on functional parameters and counteract oxidative and glycative stress induced by DHEA in the ovarian microenvironment. We found that L-carnitine supplementation counteract metabolic and hormonal PCOS symptoms and positively affect the folliculogenesis, the ovulation, and pregnancy rate. Actually, this is a study in which I showed only a part of the results connected to our field, so morphology, but we also observed other biochemical mechanisms. And probably this is in relation to the favorable influence of serum biomarkers of oxidative stress. However, between the two analyzed formulation of carnitine, we found that a better effect in presence of also PLC with that showed major effect in restoring the estrous cycling. This data represent the first evidence for the potential therapeutic application of L-carnitine and in particular the propionyl carnitine ester in PCOS. So this study confirms the hypothesis that the oral administration of acylcarnitine and propionyl carnitine alleviates ovarian dysfunction associated with PCOS, and that co-administration of PLC provides better activity. These molecules show great promise as treatment of at least co-treatment diet supplementation option in strategies for ameliorating fertility potential in PCOS patients. Before concluding, I want to thank all my research group that is perfectly guided by Professor Macchiarelli, and I want to thank Professor Carla Tatone, she is also a biologist of reproduction in our university, and all the other people working in this study like Giovanna Di Emilio, Loredana Cristiano, and Domenica Cocciolone. And finally, I thank you all for your attention.
Thank you, Professor Palmerini, for this very nice presentation, very organized slides. I wish that all was attending this presentation, and if anyone have a question. From Baljan, she told you this is a very beautiful presentation.
Thank you very much. Thank you.
This is very cheerful color.
I appreciate it.
Yeah, Palmerini, could I put a question, please?
Sure.
Yeah. Do you think we can administrate these antioxidants to prevent the PCOS?
Yes, actually, the direction is that. So when we have patients with PCOS, it is really suggested to immediately start the diet, including antioxidant. It's very important. Many results, not only our, but many results are evidencing the importance of a good diet with the presence of these supplements. Yes.
So do you think should it be a supplement, or should it be just a good diet with a lot of oxygen?
Of course, of course, I think that having a good diet is the best for all of us, independently of the presence of PCOS syndrome. But in case of the PCOS syndrome, we should improve the diet with the supplements.
Thank you. Thank you.
Thank you very much.
Our next talk will be with Dr. Yana Tamash. She is an assistant in Department of Morphology and Pathology at the private medical university REPRODUCTION. She is the head of the diagnostic department, ultrasound and functional diagnostic in a private clinic in Samara, Russia. Her talk will be on variant anatomy of the fallopian tube and the ovary, side to side differences and reference value. Welcome, Dr. Yana.
Good morning, dear colleagues, dear Professor Farghali. It's a great honor for me to be a speaker of International Symposium of Morphological Sciences. I and my colleagues from Private Medical University Rhodes, Radik Magzinovich Khairulin, Nikolai Alexandrovich Lysov, and Alexey Alexandrovich Supilnikov, we'd like to present our first data on research project variant anatomy of the fallopian tubes and ovaries. Can you hear me well and
Yes.
see my presentation?
Yes, yes.
Okay. So, as far as Professor Abdelazim already showed the very thoroughly the anatomy of pelvis, I show you one more time. That was our interest. You can see the appendages of the uterus. It refers to ovaries, to fallopian tubes, and ligaments. You can see broad ligament and ovarian vessels and their branches to ovaries and to fallopian tubes. So this picture shows better that uterine artery has branches as a anterior division of internal iliac artery. After division, uterine artery has ascendant branches to ovaries and to fallopian tubes. This one more picture for better understanding. So the imaging, ultrasound imaging sometimes is very challenging because textbooks and manuals on ultrasound diagnostics state that fallopian tubes are usually not visualized and can only be examined by ultrasound if there is the presence of fluid in the pelvic cavity. As you can see, this picture, we can see uterus and the presence of fluid and some structure, and we need to understand is it fallopian tube or is it ligament. This picture from living woman, and this picture not so good quality, unfortunately. I haven't a video. Is from cadaveric ultrasound imaging intravaginal, and we can see uterus, liquid, and again some structures that look very that seems to be as a fallopian tubes. With the development of ultrasound equipment, in vivo diagnostics have become possible, allowing and we can see this and we could get the anatomical information that before we couldn't, and we can research blood supply to the internal genital organs of women and to the uterine appendages that play very important role in surgical interventions in non-invasive diagnostics of tumors. As far as many of us know that most serious ovarian cancers are now thought to originate in the fallopian tubes. So this data presents as well visualization of structure. This seems to be like a pathology, but actually it's only a part of fallopian tubes. And we can see in the middle of the cycle very good that there is liquid around. And the main issues are there is little or no approach included fallopian tubes in routine ultrasonographic examination in gynecology, and limited data on in vivo blood flow in the fallopian tubes during ultrasound diagnostics, and insufficient data or actually on the bilateral differences in the uterine appendages. Our research goal of this project, it's I repeat one time, just the first data, it's one of our clinical part, because we still continue our research project. And firstly, we want to study the variant anatomy of the ovaries and fallopian tubes on ultrasound images. and classical dissections to improve the anatomical basis for methods of vital imaging of the pelvic organs, and to obtain reference values of the blood supply of the uterine appendages, depending on the site of the examination and the phase of the cycle. This ultrasound machine, Canon Eplio 300, and ultrasound scans in view on 20 female volunteers without any genital abnormalities and in the young reproductive age, and we use standard techniques. So we tried to use 3D scans for fallopian tubes, but actually we hadn't any clear view, and as well imaging was a bit challenging. And we made a dissection of two female corpses. One was formalin fixed and one non-fixed, with permission of the forensic medical expert in forensic bureau. And before dissection, we measured the structures and using ultrasound machine as well. Here I just want to present you standard techniques, because every doctor of ultrasound diagnostics, every gynecologist, of course, know how to research appendages of uterus, but for routine practice, it's not so usual, not so common to investigate normal fallopian tubes, but with a little bit extending of normal investigation, we can reach our goals, because we need to put to pay more attention to lateral sides of the pelvis, and as our American colleagues from in 2016 already described these techniques, and for them, landmarks for proving structures were the tubal vessels located posterior and parallel to the fallopian tube. I just want to draw your attention to this, because we decided to extend this statement and to investigate, to receive more information from the branches from the tubal branches of ovarian vessels and of the uterine, atria and uterine atrium. So this slide to obtain data, we used some zooming, and we just change the position of the probe, and in one picture we could receive all the measurements of the ovaries, and when we saw ovaries, we could faster find the fallopian tubes. You can see the normal ovary, and this structure was one of the projection of the fallopian tubes. When you turn the probe, you can see already like this. And after we decided to switch on Doppler mode, and you could see some vessels. The color window was positioned alternately in the projection of the ovary first, and then the fallopian tube. So there we use some kind of filters that names the low flow for moderate blood flow, about around 10 centimeters per second. And low frequency component, we can using some presets, we can see this picture. Small vessels and their Doppler characteristics we can measure, and this This was the recommendation from the American colleagues to use power Doppler. Actually, for us, it was, we couldn't get so much information. Maybe we tried to do it again because color Doppler showed us more information. We totally 22 women, and ovaries we can see most of the time, and location of the ovaries were typical as in textbooks and literature described in the lateral walls of the pelvis, typical position in 4 cases asymmetrically, mostly on the projection of the posterior uterine space. And one more time, I want to emphasize there was no abnormalities as adhesions, so something like tumors. There was normal uterus, and 2 cases show symmetrical high positions of the appendages. So most of the ovaries located typically. And of course, we received some data from ovaries blood supply, but it's too early to need additional research before final conclusions. But it was in comparing with the already existing data, we hadn't any big differences. But however, I want to draw your attention to arterial blood flow in fallopian tubes, because the healthy fallopian tubes we could see in many cases as well, with a 2-dimensional grayscale mode, and when we switch on Doppler, color Doppler, we can see small vessels. Of course, we couldn't measure with caliper the size of the vessels, but we can see some kind of bidirectional blood flow spectrum and linear peak systolic velocity. We can measure as well as automatically to obtain index of resistance. This picture presents some patient without any complaints, without any abnormalities in the middle of the cycle. So we can see one more picture and video. Sometimes, yes, it was a bit challenging, and we are still looking for possibilities to improve our imaging. Some quantitative analysis of blood flow in fallopian tubes. You can see that different menstrual cycle phase, we received different data. But if you compare to the data from, it's not, this one is our data, and this for comparison is not our data, but it's data from intratumoral hemodynamics that shows that tumoral, some masses, they have low resistance index, and resistance index, it's close to 0.4. Of course, on some days we received quite low index, but in the median it was a bit higher. And one more data about linear peak systolic velocity that we received, it is the median, and comparing with the tumor blood supply, that we can see that it's quite higher. And for tumors, it's predominantly of moderate to marked intensity blood supply. It's led me to our conclusions that we received morphometric and topographic anatomical data from ultrasound as a primary method of non-invasive diagnostics. We can see that anatomical variants of the ovarian location are a manifestation of individual anatomical variability, and the reference values correspond to the physiological perfusion of the fallopian tubes of a particular cycle phase with blood flow of moderate intensity. Thank you very much for your attention, for your time. We are grateful to all our colleagues and supervisors in Russia, from private medical university Rhodes, from the clinical base clinics of Dr. Kravchenko in Samara, Russia, Samara Regional Bureau of Forensic Medicine, and a group of companies, Mother and Child, and we continue our research anatomical stage and receive some support from Austrian Agency for Internationalization Foundation, and we continue our research in the Medical University of Graz in Austria as well. Thank you very much. If you have any questions, I'll be glad to answer you.
Yana, thank you from all of us for your message, okay, for our message.
Thank you so much.
Thank you, Dr. Yana, for your nice presentation. And there's a question from Dr. Abdelazim. He asked you if saline sonohistography can improve the visuality of fallopian tube or not, if you use the saline infusion sonohistography.
If I correctly understand, you mean in vivo imaging or cadaverous imaging with using saline? What do you mean? I'm sorry.
To inject saline inside the uterus and tube.
Okay. For investigating in living women, we didn't use any saline. However, when you research cadavers on imaging, already inside a kind of more liquid inside pelvic floor, we didn't use any, it was like a natural, we didn't use any saline, if I asked to your questions. Okay, thank you for your question.
Okay. I want to welcome again Professor Maria Grazia Palmerini from La Cola, Italy, and she will talk about the ultrastructure analysis on Narcon testes after the Fukushima nuclear power plant accident. Welcome, Professor Maria.
Thank you very much. I cannot share my screen because there is the previous presentation. Okay, no, I think I can. After the Fukushima nuclear power plant accident in the Fukushima area, a large amount of radioactive substances, especially iodine, cesium, and tellurium, that are volatile elements, were released into the environment. The Fukushima prefecture established an evacuation area of about 20 kilometers that were then lifted by April 2017 after the decontamination of radioactive materials. In that evacuation area, apart the accident, but it was established an archive system of livestock and wild animals, because in that area the presence of humans were forbidden. That's why animals increased significantly. And after that accident, raccoons invaded human residential areas and also damaged non-residential buildings. They grown up because of the absence of anthropic pressure. So Fukushima Prefecture is trying to control the population of raccoons that were exposed to a low dose rate of radiation, but the exposure is chronic after the accidents. Due to the biased risks in germ cells and early developmental processes, the effect of radiation on reproduction and development remain unclear. So the consequence of this accident made the Fukushima Prefecture a unique model to study the effect of radiation. That's why we aimed, in collaboration with a very big number of universities in Japan, we performed an ultrastructural study by light and transmission electron microscopy to better assess the reproductive functions of raccoon testes exposed to chronic and low dose rate radiation. To this aim, in Japan, male raccoons, Froshon lotor, were captured in different areas of the central Japan. Animals were anesthetized and then euthanized, and testes were removed. Different kind of analysis were performed in the study, but today I'm going to show you the results of the morphological and ultrastructural study. So part of the testes were sent to Italy for the histological analysis and for the ultrastructural analysis. Exposed samples were sampled at the area evidenced in yellow, so in the Fukushima and in the Nami prefecture. The red circle indicates the nuclear power plant. Differently controlled animals were collected more than 400 kilometers far from the nuclear power plant in the Ahmadi region. In this table, I'm presenting you the number of the animals sampled in the Fukushima and in Ahmadi. Just to remember that Ahmadi is controlled area. We can see that the animals were both in a non-reproductive and reproductive season. The body weight ranged from about 5 to 7 kilos, and the radioactivity changed a lot among the animals. Today, I will present data about the samples number 16, 17, and 18 that are representative of a condition of low, medium, and high exposure among the low-dose radiation. In Italy, samples were prepared according to our standard preparative in our lab. Here I'm showing you Dr. Belli, who is cutting the semitine section, and observations were performed in the Center of Electron Microscopy at the University of L'Aquila. After immunohematoxylin eosin staining, we didn't see actually any differences between the Fukushima and control group. In particular, on the top, it's showing samples from animals at non-reproductive season, so we can see well-preserved seminal tubules, but of course it is not evident the presence of elements at maturating elements of the germline, so we can see spermatogonia, but no more. This is both control and Fukushima samples. Differently in the reproductive seasons, again, numerous tubules were visible, and all the lines of germ cells is evident, ranging from the spermatogonia at the basal level and moving toward the abluminal compartment. We can see also spermatid and spermatocytes, and even elongated spermatids. By counting the number of the cells inside the tubules, we found that it was observed an increase in the cellularity. It means that the mean number of germ cells and in this case for germ cells, we indicated spermatogonia, spermatocyte, and spermatid, but also the number of elongated spermatid increased in the Fukushima sample, in the Fukushima testis. Moving to the results obtained by electron microscopy, we could see again a better definition. So we can see the tubules delimited by a thick basal membrane. Here we can see a spermatogonium, Sertoli cells, and spermatocytes. Spermatogonia were very round with a roundish nucleus. It is visible the very electronegative nucleolus inside. Sertoli cells were characterized by an indented nucleus with the presence of a very, very electron-dense and vacuolated nucleolus. And if we follow the outline of the cell membrane, we can see that the Sertoli cells, as normally, are distributed from the basal compartment up to the luminal compartment. And here we can see the presence of interstitial tissue with some phenomenon of vacuolization. On the right, we can see again another spermatogonia, and we can see numerous spermatocytes at the cup face with the proacrosomal vesicle well evident. These are also spermatocytes, but in different section planes, so we cannot appreciate the proacrosomal vesicle. With the asterisk is indicated the occasional findings of partial detachment from the interconnection between adjacent cells that we found in here and in here. In picture in micrograph C, it is shown two spermatogonia very close, and we found also the presence of intercellular bridges that in these stages are, can be occasionally found. Another phenomena in which we found a partial detachment, but in this case, the partial detachment affected the nuclear membrane. This is a spermatocyte with a round nucleus, and we can see the detachment between the nuclear membrane and the cytoplasm. Numerous mitochondria are very well visible in section. Just to notice that this mitochondria had a vacuolated aspect, as also indicated in here, in these cells, in which we had a transversal section showing the presence of cristae in section and the presence of tubular or roundish vacuolated mitochondria. Moving toward the abdominal compartment, we can see the presence of maturating elements. So there are round spermatids together with elongated form of spermatid at different stages of maturation. Here, for example, we can see the acrosomes that is enveloping the nucleus and moving on the back. And the presence of residual bodies is visible and is indicated here with the asterisk. So spermatozoa are having the correct maturation, and they are perfectly present inside the Sertoli cells niche. And here in H, we can see different numerous spermatozoa. We can see, of course, the tail at the middle section, a different length of the tail in transversal section. Moving in the second group, exposed to medium radiation, we can see by semi-thin section that the lumen was an increased cellularity, as we already described previously. So the lumen is very narrow. Basal membrane is again thick. We can see also the presence of adipocytes in the interstitial tissues, while in the basal compartment we could see numerous spermatogonia together interspersed among Sertoli cells. This is very nice to see the indented profile of the Sertoli cell nucleus and the presence of numerous lipid droplets characteristic of the Sertoli cells. Also in here, And here it is visible at tight junctions between adjacent Sertoli cells that will organize the compartment, the hematotesticular barrier. In these two micrographs, we can see the presence of numerous elements of maturating spermatogonia, spermatocytes, spermatid, and elongated spermatid. We can see again the presence of cup-like spermatid, elongated spermatid in here, and the presence in the lumen of numerous residual bodies. So everything, it seems, is going well. At the highest exposure of low dose radiation, cellularity is again very, very high. In this section, the lumen is even not visible by 17 staining. 17 section staining. Electron micrographs show a basal membrane with myoid cells, very well visible. Spermatogonia Sertoli cells made the first line. We can see the vacuolated nucleoli of Sertoli cells. And the second line was made by spermatocytes with a nucleo and slightly electron dense. And here we can see interspersed between numerous spermatocytes, elongated elements growing up. Here there are numerous mitochondria, again vacuolated, and we can see very well the outline of the mitochondria membrane and of the internal crystal. On the left, on the right, sorry, we can see numerous elements in the lumen, in the abdominal compartment, with the presence of elongated spermatids, but we can also see spermatozoa, and in particular, we are observing the tails cut in transversal sections. The presence of residual body is very, very big, numerous. We can see residual bodies attached to the maturing spermatozoa. So these results obtained by transmission electron microscopy evidence that Fukushima raccoon testis didn't evidence remarkable changes in spermatogonia, spermatocytes, spermatids, or elongated spermatids. However, radiation-exposed raccoon testes had occasional increased cellularity with respect to controls during the reproductive season, but this may be due to a slower spermatogenic regression in control samples, not in the Fukushima. So the problem can be that the animals living in the control area, that is more in the north, had a slower spermatogenic regression respect to the samples collected in Fukushima. And this delays the reproductive season in control animals. Signs of ultrastructural alteration were occasionally evident in terms of presence of cytoplasmic folds in the spermatogenic cell line and detachment of germ cells from the adjacent cells. No signs of tubular atrophy or cellular undifferentiation were detected. We can just hypothesize that interstitial spaces found dilated, where we found the partial detachment, may be indicative of a phenomenon of initial fluid accumulation and therefore initial edema. But of course, we need to confirm this hypothesis. So in conclusion, although the reproductive organs are hypernormally well-known, hypersensitive to radiation, the presence of a chronic exposure to low level of radiation after the Fukushima nuclear power plant accident seems not to induce evident ultrastructural alteration on raccoon testes and spermatogenesis. And again, before concluding, a special thanks to our big head, Professor Macchiarelli, Dr. Manuel Belli, and to all the Japanese groups coming from the Niigata University, Aomori University, Hokkaido University, Tokyo University. The list is very long. I will stop here. Thank you very much all for your attention.
Thank you, Professor Palmaini. Anyone have a question?
So can I?
Yeah.
Sure.
Thank you. Good afternoon again, dear colleagues. Dear Maria, thank you for your very beautiful and correct research. But I have one question. Why do you use raccoons as an object for investigation? We know in many mammals, structural organization of spermatogenic epithelium is the same. Okay. So
in mouse, sorry, in mouse. I didn't understand. Sorry.
Why do you use raccoons as a model?
Okay, sorry.
But not other species of animals, of mammals.
No, actually, we are making a very big project because we're studying the effect of radiation in mouse, in Apodemus speciosus, that is the wild mice living in Japan, in this model that I presented here, and in a very important model of primate, the macaca, the Japanese macaca, Macaca fuscata. The aim is to evaluate the effect of radiation in different mammals. Of course, the most important data will be, of course, in the primate model that is very indicative also for the effects on human. So today I presented data on raccoon because are more recent. In the next future, we are going to publish the paper about the Macaca fuscata.
Thank you very much.
Thank to you for your question.
Thank you, Professor Maria. Next talk will be by Dr. Atmao. She's a PhD student, Department of Normal and Topographical Anatomy, West Kazakhstan, Mat Osmanov Medical University.
Thank you, Professor.
She will talk about morphological finding of benign ovarian neoplasm in West Kazakhstan.
Thank you. Dear Professor, dear colleagues, let me introduce a report on the topic morphological findings benign ovarian neoplasms in West Kazakhstan. Next, please. Next slide, please. Ovarian tumors and common pathology and represented 6–11% of tumors of the female reproductive system. 70–90% of them are benign ovarian neoplasms. Unfortunately, the amount of tumors in the reproductive age is 90–25%, in the postmenopausal period 20%, during pregnancy up to 5%. It is known that malignant tumors develop from benign tumors, and more than 230,000 new cases of ovarian malignant neoplasms are registered annually in the world, and the mortality rates 150,000. The incidence rate in developed countries is 9, in developing countries 5, in the Commonwealth of Independent States 6.7 per 100,000 population. According to scientists, the peak of the disease falls on the working age from 50 to 54 years. The detection of malignant tumors was noted at the age of 55, 65. Thus, unfortunately, the benign ovarian neoplasms to become malignant. The early days in the study, the prevalence clinical morphological features of the ovarian neoplasms in women is very important. Please, next slide. Next slide, please. A retrospective analysis of 318 patient histories was carried out for 2016-2018 years. The work had a number of inclusion and exclusion criteria. Next, please. Next, please. To the result of average age 33 years. The prevalence of the benign ovarian neoplasms falls on the reproductive. When analyzing the histories of the disease, more than 50% were background disease of the uterine appendages. Next, please. Next slide. It was found that when analyzing the circumstances of detecting ovarian neoplasms in patients, about 70% of the examined patients, benign ovarian neoplasms were detected by ultrasound examination, which was performed during the investigations or during checkups. Next slide. According to the World Health Organization classification, a significant part of benign ovarian neoplasms is represented by an epithelial histotype more than 50%. Please, next slide. Next. Among age groups, the most previous slide. Among age groups, the most common type is serous cyst, and it is often associated with functional cysts. Next. On the basis of continued prospective study, the study was based on the analysis of the risk malignancy index calculation according to the following formula. In the pre-operative period, used parameters the Cesium CA 125 level, the menstrual status score, and the ultrasound score. Next, please. Ultrasound assessment was based on the following ultrasound parameters. For example, ultrasound score is 1 if one ultrasound parameter detected, etc. Next, please. High-level relative malignancy index above 200 is observed in premenopausal and postmenopausal groups, were observed in patients with serious cystoadenomas of multicameral, papillary type, and the mucinous cystoadenoma. Next, please. Also, research by scientists indicates a high information content of the use of relative malignancy index at the primary stage of differentiation. Next, please. Conclusion. Next, please. Conclusion that benign ovarian neoplasms were more common in the reproductive age group, and the conducted prospective study indicates a high information content of the use of relative malignancy index at the primary stage of differentiation. The multimodal relative malignancy index is simple, practical, and a reliable operative tool for primary evaluation of suspected ovarian mass than its individual parameters for exclusion of ovarian malignancy. From a morphological point of view, serous cystoadenoma is often found in the premenopausal and the postmenopausal groups, especially the risk of malignancy is high with papillary type. Thank you very much for attention.
Thank you, Dr. Ahmadi. We don't have questions. So our next presentation will be by Dr. Tatiana Shudonova. She is working in Department of Pathology in Chevenov First Moscow State Medical University in Moscow, Russia. She is first prize winner in Pathology section of Medical Splendid Conference 2020 in Chevenov University in Russia, and she is participant in the Science for Health Conference in 2019 and 2020. She will talk about the preterm birth morphological features in the gestational surrogacy. Welcome, Dr. Titiana.
Good afternoon, dear professor, dear colleagues. Should I share my screen?
Yes, please start. Yeah, hello, please start.
Can you see my presentation?
Yes,
but
Alisa.
make it a slideshow, please.
Okay.
Yes.
It's an honor for me to represent for you our study conducted in Septum University. And the topic of my presentation today is preterm birth morphological findings in gestational surrogacy. We will talk about two types of surrogacy: prevalence of adverse pregnancy outcomes in gestational one, and proposed mechanism of pregnancy complication. After that, I would like to present to you our study and some literature data. So let's start with the definition. There are two types of surrogacy, traditional one and gestational one. The main difference between these two types is the oocyte origin. In traditional surrogacy, oocyte belongs to a surrogate mother, whereas in gestational one, it is received from a commissioning mother or from a donor. It is known that surrogate pregnancy is associated with increased risk for the development of adverse pregnancy outcomes, and this slide shows some complications of gestational one. These data were obtained from a recent study conducted at Septum University, and the most common complications were threatened abortion in first trimester, threatened preterm birth, and directly preterm birth. That's why we decided to carry out a research among surrogate mothers with preterm birth delivery. High prevalence of complications in surrogate mothers cohort can be explained by the maternal sensitization to fetal antigens and violence of the immune tolerance. In this slide, you can see a scheme of the inheritance of 5 or more immunogenic human leukocyte antigens that encode the related proteins of major histocompatibility complex. In spontaneously conceived pregnancies, as well as in pregnancies conceived by in vitro fertilization with autologous oocyte, fetus inherits one set of these genes from the mother in the color orange, and one set from the father in the color blue. And in this case, a maximum of 5 mismatches between mother and fetus can occur. So fetus will be semi-allogenic for the mother. In gestational surrogacy, fetus inherits one set of genes from a donor and one set from a father. And in this case, fetus will be fully allogenic for the surrogate mother. That's why that's why in this case, more frequency of complication can be seen. On this slide, you can see meta-analysis conducted by Strogan et al. And this shows higher frequency of pregnancy complication in oocyte donation group compared to spontaneously conceived pregnancies and in vitro fertilization group with autologous oocyte. And this data could indirectly confirm immune origin of pregnancy complication in gestational surrogacy. Assuming the immune pathway of complications development, we expect to find tissue lesions on the border between maternal and fetal tissues. And this border includes decidual tissues, in situ trophoblasts of the villus tree, and cytotrophoblast cells in the placental bed. The main aim of our study was to determine what morphologically underlies preterm labor in gestational surrogacy, and either to confirm or deny an immune inflammation present. Our study included a total of 120 pregnancies resulting from in vitro fertilization with donor eggs under the surrogate motherhood program. We divided it into two groups, women with preterm delivery and women without any complications. Macroscopic study, histological examination, and immunohistochemical analysis of obtained placentas were conducted. This slide shows inclusion and exclusion criteria for our research, and I would like to present to you the results. Histological examination of placentas in preterm birth group demonstrated a higher incidence of chronic deciduitis in 72% of samples, pyruvillous fibrin deposition in 44% of samples, and massive fibrin deposition in placental tissue in 31% of obtained placentas. The difference with the comparison group was significant. P was less than 0.05, and immunohistochemical analysis with antibodies to CD8+ and CD138 revealed cytotoxic T leukocytes and plasma cell respectively. And I would like to show you microscopic findings in the surrogate mother placenta. This slide shows decidal tissue. On the left-hand side, you can see microphotograph with low magnification that shows the presence of chronic inflammation foci in the fetal membranes, and decidal tissue represented by leukocytes, macrophages, and plasma cells. On the right side hand, there is a high magnification microphotograph of the same sample. You can see decidal edema and prominent plasma cell infiltration. The presence of chronic inflammation was found in the decidal tissue and the chorionic villi. The cells that characterize chronic inflammation infiltrate decidal tissue and subbasal intravillous space. Cells are represented by leukocytes, macrophages, and multiple plasma cells. These microphotographs show chorionic villi. You can see a vascular villi with stromal necrosis, lymphohistiocytic infiltrate within villi, and pyruvillous fibrinoid deposition. There are also presence of leukocytes, macrophages, and plasma cells within intravillous space. We used immunoperoxidase staining with CD8+ antibodies to verify cells that underlie chorionic villitis. You can see cytotoxic T leukocytes in the color brown, which are localized in the villus stroma. The next slide shows CD138 positive staining in decidal tissue. CD138 is specific for plasma cells, and you can see its large amount in the decidal tissue. Some literature data. According to the literature, the most common finding in placentas obtained from subset of patients with preterm birth were chronic deciduitis, chronic villitis, and chronic chorioamnionitis. Lesions such as chronic deciduitis and chronic villitis are more often revealed in placentas obtained from pregnancies conceived by in vitro fertilization with outside donation. The proposed immune mechanism implicated in inflammation process resembles an allograft rejection and consists of cell-mediated and antibody-mediated pathways of damage. Now let's move on to the conclusions. Chronic inflammation on the border between fetal and maternal tissues and presence of plasma cell and cytotoxic to leukocytes confirm immune pathway of preterm birth development. According to the literature, lesions revealed in the studied group resembles an allograft rejection that can cause the high prevalence of preterm labor in the studied groups. Our results correspond to scientific knowledge, and in relation to the surrogacy, the most promising way to prevent pregnancy complication with underlying immune inflammation may be careful selection of oocyte donors to minimize HLA mismatches. The algorithm of donor selection should be similar to that in solid organ transplantation. Thank you for your attention. I'll be happy to answer your question if you have any.
Thank you, Dr. Tatiana. If there's any question on this presentation or previous presentations.
Professor Farhali, there was a questions to the previous presentation.
I didn't see any.
Yeah, the chat from Professor Abdelazim.
Only thank you. Can't see anything. Yes, this is a comment from Professor Abdelazim about the previous presentation that is important to discriminate between benign and malignant ovarian masses. This is for Dr. Ahmadi.
The risk malignancy index, we are using the risk malignancy index. This is why in the previous presentation.
Yes, Dr. Ahmadi.
I mean, she's using the risk malignancy index for differentiation between benign and malignant ovarian masses preoperatively before going to surgery.
I think she is no longer with us, Dr. Ibrahim.
This is just a clarification and not a question. I am clarifying why you are using the risk malignancy index preoperatively for differentiation between either it is benign or malignant masses, because the intervention surgically will be different.
Okay. Okay. So no more questions.
Thank you, Professor Ibrahim. About my presentation.
Thank you, everyone. Thank you for participating.
Professor Tatiana, it's a very nice presentation because the implication of chronic inflammation in the preterm labor is something well known in the evidence that we prevent the chronic inflammation, deciduitis, or chronic inflammation for prevention of the preterm labor. Very logic and well-organized presentation. Thank you for the presentation.
Thank you very much.
I want to thank the organizing committee team in Al-Farabi Kazakh National University in Almaty and West Kazakhstan Mat Osmanov State Medical University, and a special gratitude to Professor Galmea Zohabekova for her kind invitation, and thank you, Balzan, for your participation and organization.
Thank you. Thank you for your kind moderation.
Thank you for the participants.
Yeah.
See you.
Thank you.
Thank you to all.